Thank you. Wow. You can see how desperate I am as I'm hanging down there and waiting to be called up. But you know what? It's such a delight to be here. And my biggest association with Wales is that polypharmacy in old people. And I was saying to Claire, if I got a penny for every time I mentioned it or recommended it to someone, I would be a rich lady. So it's a really well put together document. So it's nice to be speaking to all of you this sunny day. Greetings from London. Yeah, so I work as a consultant pharmacist and I work in the community. I'm very community based and I work at Guy's and St. Thomas's. And when I'm not in people's homes or in a GP practice, I'm in that little office there. And there's a community health center and they have all kinds of things there from social services to offices. In my other job, one day a week, I work for the ICB, Southeast London ICB. So Southeast London is one of 5 ICBs in London, and we're a very interesting group of people. We're a very diverse population in every sense of the word. So we have people from all ethnicities. We have rich, poor, and all the in-betweens. And we have people that are very difficult. Frailty comes in a bit early because of deprivation. So we see quite a lot of polypharmacy and multimorbidity in younger groups of people. We have a huge population of asylum seekers and immigrants, and we have also a big health inclusive team that looks after people who are sex workers and also people who are alcoholics and have drug abuse. So it's a really interesting place to be working. Okay, what am I trying to do today? First of all, I don't think I really have anything new to tell all you guys who are sat around here, but I'm hoping that there will be something that really catches your attention that's going to change your practice and help you to shift the narrative a little bit around problematic polypharmacy. And I'm really hoping that you'll meet some of my patients as we go along. So I just say sit back and relax. As you probably all know, polypharmacy is a complex issue. If we had the answers to it, I wouldn't be standing here, and neither would you. It's really complex. There are many facets to it. There's a lot of interdependencies, and we can only do the little bit we can to make things slightly better. So I've assumed the majority of you here are practitioners, so I'm not talking too much about policy because I'm talking to people who are at the coalface of practice and who can really make a change in the lives of patients. So before I get started, I have a few slides, but I just wanted to know who's in the room. So just put your hand up if you work for primary care. Fab. Secondary care? Ooh, nice. Any pharmacists in the house? Yay! Any doctors or medics? A few of you. And then any other people? Physios, nurses? Wow, what a mix. Oh God, I'm excited. So today we are going to be I'm just going to be focusing on frail older people with multimorbidities, but this can work for any group of people. A bit of statistics. So this is why it's really important. So we know we have an aging population, and we're going to see within that aging population, the people who are over 85 are going to be double in the next 40 years or so, 20 years or so. We also know that about half of those people who are over 85 would have some form of frailty or the other. 50% of the people who are over 85 and are in hospital today will be dead within a year. So we need to be having conversations about medicines, especially the medicines that they're not going to benefit from because they're not going to live long enough and they're causing problems now. So that's a shift. But also we know that for people who have severe frailty in particular, majority of them would have less than 3.5 years. So again, we're not prescribing for the 10 years to make a little shift in end stage macrovascular or microvascular problems in diabetes. We're almost looking at the here and now. How can we keep them within not making them hypo or hyper, and just keep them nice in the middle so they can do all they want to do. So we know from some of our Age UK data in England that 1 in 4 people who are over 85 are taking at least 8 medicines. That's huge. And we also know that from the National Overprescribing Review that 1 in 10 prescriptions in primary care may not be appropriate. That's a whole load of medicines. In my patch, we spend millions on medicine. So if you think that at 10% of that, it might not be necessary, then you can understand that just the why this is so important from a cost perspective. If you go to care homes, the average 65 to 69-year-old in a care home takes 3 times more medicines than their counterparts at home. And if you're taking 10 or more medicines, you're 300 times more likely to be admitted in hospital for an adverse drug reason. So there's a lot going on with medicines. So I've talked about health costs. I've talked about the fact that 30 to 50% of medicines are not taken as prescribed. If you look at my cohort of patients, I've never seen a patient who takes every single thing how we ask them to take it. So there's huge discrepancies there. And of course, there's a carbon footprint and there's a whole load of wasted medicines. And there are inequalities around gender. So I was listening to the propranolol thing. Women are more affected. There are things about age. The older you are, the more likely you are to prescribe many medicines, the more vulnerable you are to them, and the less likely you are to have an SMR or have a medication review done. There is also issues around ethnicity, and the biggest I think we have in our patch is around deprivation and literacy. So if you're in a place with high deprivation or you have a low literacy, you're more likely to be prescribed medicines that are not necessary. So there's a lot going on there. Before we get in, I want you to, those of you who don't know what a frail person is or who, just need a bit of a refreshing. So somebody who has frailty is someone who has basically, long and short, is they have a reduced resilience to stress. So if they have just a tiny bit of a stressor, that could be a flu, it could be a UTI, it could be that they moved home, it could be that they've lost their spouse, it could be anything. And that causes a very exaggerated drop in their kind of level of independence. So as you can see there, me and you are on the green line. Oh, well, I can speak for myself. And if something happens to us, we kind of just go down a little bit. We might have somebody have to bring our medicines home. And then no sooner than later, we're back on our feet. If you're an old person who is already at a lower level of dependence, when any of those things happen, you drop all the way right down in your level of dependence. And that's the time we bring the social services in. They have to go to a care home. Or worse still, people have to go to hospital. And the journey back is just fraught with difficulty, is slow. And when they finally get back, they're not at the same level of dependence that they were before they went in. And if this happens over and over and over again, that's where we see the frail old people. And some of you must have had an auntie or a mom or a neighbor who just has a fall, for example, and they come back and it's all they look so old. And that happens enough times, they just eventually fade away. And so our job, and one of the shift is not only about whether the dose is right, the formulation is okay, is thinking, is there anything we can be doing with medicine so they don't fall off that cliff? So that's the first mind shift. It's more than just the medicines. It's about the whole system and trying not to trigger or worsen frailty. So again, just a little bit more about frailty. So we have a frailty continuum, and there's the clinical frailty score, which is a kind of an assessment of how frail people are or what level of frailty they have. And we have a fit old person all the way going down to number 9, which is when they're terminal. But again, if you look at some of the descriptions, it can tell you, and you can almost know who those people are: slowed walking and people who are completely dependent. So a lot of the people in care homes, a nursing home will probably be like a 7 to 9. And lots of the old people who are kind of just holding the bus up with their bus pass, they're probably 4 or 5 in terms of frailty. Just to re-emphasize what I said before, that's the survival curve for people who are frail. The red line are those with severe frailty. So if you think about it, within a period of 3 years, about half of them are gone. So that should really begin to shape how we think about medicines in the frail old people. So back to medicines optimization. This is kind of what we're all trying to achieve in our various roles. So this is a definition from NICE, and it says medicines optimization is a person-centered approach to safe and effective medicines use to ensure that people obtain the best possible outcomes from their medicines. So very typical, not just in the NHS, but with business people, we normally say how we do things first, and then what we're going to do and why we're going to do it. And so we say it's a person-centered approach that we need. What we're trying to do is safe and effective medicines. And the reason we do this is because we're trying to get the best outcomes. And for me, that's the first shift. So from today, I would like you to think about why. The why is the most important thing because that's the biggest anchor we have. Let's think about why we're doing this. So every time you encounter a patient, never mind whether it's a medication review, or it's a medicines reconciliation, or is I don't know, whatever it is you're doing. The most important thing is we're trying to make sure that this person gets the best outcomes from their medicines, and that should ground us. And then we think about how do we then do this and what are we trying to do? I think it's easier that way to put the patient at the center. So just some useful concepts before I just launch into all my jargon and nobody understands what I'm saying. So the first is polypharmacy. Polypharmacy basically is from two words, poly and pharmacy, many medicines. In the old days, if you looked at the research paper, 4 or more medicines or 5 or more is what's polypharmacy. When I joined, when I started working in primary care in 1999, 4 medicines almost like, wow, polypharmacy. Now my average caseload, bearing in mind that I see the most complex, it's about 15. I've seen 35 and I've seen 50. And the guy who had 50 medicines, he had no other life. He was just sort out his morning medicines. By the time he finishes, it's time for the afternoon medicines. And he just had no life. It was just around the medicines. And I said to him, I said, I'm here to make your medicines work for you, not you for your medicines. He was working for his medicines. And so polypharmacy is really just taking more than one medicine. Then King's Fund, I don't know if they're popular down here, but they're quite clever people down in London. And they came up with the fact that it's not really about the numbers because some people need to be on many medicines. And so they coined appropriate polypharmacy and problematic polypharmacy. Problematic polypharmacy is where we have polypharmacy that's not working. So that needs to be dealt with. And appropriate polypharmacy is okay. Then in 2021, we had the National Overprescribing report, and they went even a step further, and they thought it's not about numbers at all. If you're taking a medicine when we could have prescribed a non-medicine alternative, that's overprescribing. If we prescribe a drug around the indication and there's a correct indication for it, the patient doesn't want to take it, is not appropriate for their situation, that's overprescribing. And many pharmacists were not very happy because it brought the patient into the equation, and that gets really messy. We like to do the medicines, just talk about the medicines, counsel them. It's the grapefruit juice and the statin. It's all so easy. When you start talking to patients, and some of you medics will know that, it just gets messy. If you talk to the patients in South East London, it is messy. Very messy indeed. But we can't do overprescribing without the patient. Because at the core of it is they are part of the equation. It's not just about the research, it's about the patient too. And then, of course, there's deprescribing that's been floating around for a while. And deprescribing is a complex process to stop inappropriate medicines, taking into account everything about the patient. So now we're in a position where we have all these people taking many medicines that we've written, and we can't just do on the back of a piece of paper, stop. We have to bring the patient in. We have to hear their views. And this is what makes it really tricky. And that's why people just put it in the difficult box, and things are getting worse and worse. So let's go back to evidence-based medicine. Evidence-based medicine, we all know, is all about integrating the expertise that we have, bringing the patient in the conversation, and tying that all, or linking the research to that, so we can choose what is right for the patient. Is beyond what happens in the clinical trials, because in the real world, people have lives, people have other diseases. A lot of the guidelines around a single long-term condition. I was just speaking to some heart failure people in secondary care this morning before I came, which is why I couldn't be here from the start. And we looked at comorbidity in heart failure, and 90% of people who have heart failure have at least 3 to 6 other long-term conditions. Meanwhile, the heart failure guidelines from NICE is just about heart failure. So it's almost impossible to use. And this is what brings all the nuances and complexity. So shared decision making is almost your get out of jail card, is what helps us to tailor the evidence base to what's wrong with the patient. So shared decision making is a key thing. And the lines are a bit wonky, not because I couldn't really do the thing, but it's just to show that it's not a smooth and clear process. It's wonky, and it's quite difficult to do. So what works? We had a nice multi-morbidity guidelines. It was interesting that they came up and said, honestly, we were expecting them to have all the answers, and they came out and thought, do you know what? We can't do this. Here is what you need to do. We don't know what the answer is, but there's some things that you can do that can make you work. Number one, we need to optimize their care by reducing the treatment burden around polypharmacy and multiple appointments. That's too much for patients to handle. We have to reduce unplanned care as well. No unnecessary visits to the GP, no unnecessary visits to the hospital, only when it's appropriate. And also, if we can improve people's quality of life by shared decision making around the things that are important to them, around their treatment and around their health priorities, their lifestyle and their goal. But then that's difficult, because for frail older people, there's a lot of stuff. There's the pharmacokinetics and pharmacodynamic changes that require adjusting of doses, because the people are taking so many medicines and they have so many conditions. Everything is interacting with each other. You prescribe something for heart failure, the patient doesn't want to go to the toilet. They go to the toilet and then they have a fall. They have a fall and they crack their hip, and then they're kind of housebound. Then that makes them depressed. And then you have to put them on SSRI. And it just goes on and on and on, because it's so complex. And sometimes we have to take a step back and really say, in the middle of all these, what's the best thing you need to be taking? What's really important to you now? And we have to then align medicines with that. And then, of course, there's the pill burden, like I said, with that man. Just too many medicines, and people want to live a little bit, rather than just being there, just collecting medicines and dispensing them. Also, there's a shift in goals. Frail older people tend to value generic outcomes. It's about function and all that stuff. I've never met an old person, and maybe it's a Lambert thing, who's interested in their HbA1c. They really don't care. Where we live, they don't. They just want to go out with their grandchildren. So we have to learn to speak that language, because we are all, proxy measures and, blood pressure tablets and blood pressure measurements and all kinds of things. And the people who live where I am, they really don't care. They just want to know, is this going to allow me to go to bingo? And if the answer is yes, they will engage. So, we have to begin to speak the patient's language. I talked about pill burden. A lot of people, I say, even if they don't have dementia, they have mild cognitive impairment. And it's just too much, especially like with the new inhalers. I have a problem with them. I just can't work them out. They're so different. And, we expect these people, the Novo pens and, press the bubble out. It's too many steps for an old person. And sometimes we just need to think about all that, as well as them managing every other thing in life. Constantly changing circumstances. And of course, there's all the ethics and legal aspects about, should I stop this medicine? We don't have that many guidelines on prescribing, and this is what contributes to some of the things. So I just want you to meet this patient. So we discussed this at Case Huddle, not just about 2 weeks ago. I don't know what the outcome is, but we had a conversation with the pharmacist on how we're going to manage this. So some of you might recognize this kind of patient. So it's an 83-year-old, is housebound, is multi-morbid, very slow mobility, is unsteady on his feet. He has a walking frame. He has visual and hearing impairment. He just lost his wife, so he's trying to get back to normal. He's losing weight quite rapidly. Has many medicines, moderate frailty. He has AF, osteopenia, asthma, and so on, and he has capacity. So when you look at those medicines, you think nothing really wrong, until you bring the patient in and it gets messy. So he went to hospital, and he went to hospital because his legs were swelling. and he had cellulitis. So he fell down, and they took him in, put him on antibiotics like you do. They whacked up his furosemide dose and gave him all the other things he needed to, because really we want to get that heart working. And from a medical point of view, we were fine until he got home and he recognized that he's going to the loo every single time. And then he stopped taking the medicines in light blue. No eplerenone, no furosemide, no tamsulosin. Sometimes patients, even though they don't have clinical, they can just pinpoint the right medicine to stop when they have symptoms. I don't know how they work it out. But anyway, he's not taking any of these medicines because he doesn't want to be going to the loo all the time, and he doesn't want to fall down. He wants to get back into society. So we have a misalignment. We have every single challenge I spoke to you about, therapeutic competition. So there's competition between his leg and his heart, and also the fact that he has osteopenia. So he is very prone to having a fracture. Once he has a fracture, that could be a game changer. He might never leave home at all. So he's quite upset about this. And the question is, what do we do now? Because they're conflicting and competing priorities. And this is kind of the general story around polypharmacy. I don't know how many of you ever have this kind of dilemma, or is it just an England thing? Put your hand up if you've ever had this kind of dilemma. Yeah, we have it all the time. And so for this particular patient, we're going to, at some stage, have a conversation with him, with everybody sitting around the table. I noticed that the cardiologist goes, nobody should ever reduce his furosemide dose beyond 40. And I thought, good luck to you, because the patient has done that himself. So at some stage, we're going to have to come to an agreement about what's best for the patient, as long as what he wants. And those are the conversations we need to have. I don't know what the outcome is, but if I was there, I would be looking at the furosemide dose and encouraging the patient to take some. Not even if he doesn't want to take, because otherwise, if we enforce that, what he's going to do is do exactly what he does, and he's not going to take them, and he's going to keep spinning into hospital. So this is the shift. We are in a new era where the patient matters as much as the clinician. We're equal partners in care. So when do we have to consider deprescribing, when do we have to address problematic polypharmacy inferiority? I would say this is part of routine care. But particularly if they have a short-life expectancy, if they're not taking their medicines in spite of everything we've done, if the patient asks, and a lot of patients ask for us to stop some of their medicines. Sadly, the medicines they want us to stop is the ones we want them to take. And the ones we don't want them to take, like the painkillers, that's what they want to take. But if they ask for it, we need to consider it. If the medicine is not working, if there's potentially inappropriate medicines, if there's therapeutic competition, and if the medicines are working against the overall patient's aims and objectives, we need to consider stopping them. And of course, when people pass from one care setting to another, is a time to review medicines and to check the old ones, whether they're still working. So can we all do this? I think we can. So I've got another patient, and I'm going to just kind of run through with you, and you guys, I want to see your thinking. So for example, let's look at the information we have about the patient. Look at the lifestyle. Look at the current, history. Look at her current function. Look at her test results and the most recent consultation, and just eyeball her medicines. I'm going to give you a moment to do that. Okay. Somebody tell me what you're thinking about the medicines. Do you think there are any problem medicines there? Somebody shout out. So I'm not talking to myself. Sorry? There's a lot of medicines, yeah? She's only a little lady. Thank you. That's called a prescribing cascade. Look a bit deeply. Just look at the old lady and some of the things, even without the medicines. Just look at some of those things. Those are the things that really stuck out to me. So she has little exercise. She drinks a little bit. Her blood pressure is a bit low. I mean, we didn't do a sitting or standing, which is what I would expect people to do. But I'm thinking falls already. I'm seeing that her pain is kind of well controlled. It's not so bad. And there is no neuropathic element. So what is the amitriptyline doing there and the gabapentin? and they can cause terrible side effects. I'm thinking about what's really important. I'm going to have the granddaughter there that she picks up, and that's really important. And she's kind of having a bit of dizziness, and so that's affecting and impacting on the daughter. Now, this is a typical case. When we look at the patient history, and this we all got from the care records and the patient's notes, there's always something that is important to the patient that we can link with what's important to us. And for me, that's where we start the conversations. So I had a little thing before I went to see this old lady. And I thought, for example, if we didn't have that cocodamol and we didn't have amitriptyline and we didn't have gabapentin, just if, I'm not saying we need to stop it, maybe we wouldn't need to prescribe the 2 laxatives. Maybe. If we didn't have amitriptyline, we might not have to prescribe the sulfenacin because it has an very high anticholinergic burden score, causes urinary intense, and it causes dry eyes. Very common. And amitriptyline has a very high anticholinergic score, 3. Maybe if we didn't have the bendrofluoride, maybe we wouldn't have the sulfenacin. I'm just saying. Or maybe if we didn't have the omeprazole, we wouldn't have the B12 deficiency. And maybe atypical fractures. Lots of stuff. And maybe if we just got a social prescriber, I don't know if you have them here, but we have social prescribing link workers who you can refer a patient to, and she can get some of that whole stuff sorted out about the fact that she's at home, she's not going anywhere, she has little exercise. Mobility and exercise and meeting people can help with pain and help with a whole lot of things. But I'm just saying that everybody in here can do something about a lady like this. And maybe that's a shift we need to think. There is something I can do within the whole thing, even if you can't think about everything, because there's a lot of scope. The system we have now is quite messy, so there's a lot of scope to do something about problematic polypharmacy. As colleagues and I, we looked at all the information that's out there and all the research, and we came up with whatever system that is out there. There are essentially 7 steps, and there's a Scotland one, and there's so many other tools. There's 7 steps that you have to go through, or that's good to go through in your encounter with very older people and medicines, especially if you're doing a medication review. And these 7 steps are: number 1, we have to have a way of assessing and defining the context and the overall goals for the patient. This is where we ask, where we check the medicines records. Are they taking all the medicines? Because often they're not. Are they taking all the medicines? What's the most important thing to you now? So we have to do that. We gather the biomedical data, contextual data, and try to understand a little bit more about the patient. Then there's the bit about the evidence base. So we need to use the tools that are appropriate to highlight medicines that are potentially inappropriate. Some of them you'll know depending on your scope of practice, and they're tools to help when you don't know everything. And then at some stage in the lilac bit, we have to bring those things together and think, here is the evidence for a general population. And then from what I've heard, how can we bring the 2 together for the patient who sat right in front of me? And then we have that conversation together. We explain risk and all the, I don't want to do this, I don't want to do this. And we finally arrive somewhere that we want to arrive at that consultation. We agree what we want to stop or start or change or wait and see. And then we have to communicate with every other person who's involved and seek advice sometimes. And then we have to monitor and review that patient. So all those things, not necessarily in that order, have to come into play at some stage if you really want to do a patient-centered review. So this is not where you write a letter to the patient and say, oh, well, you know, we're in good practice, and so we're trying to change the number of your medicines, your pain medicines, because 90% of people don't benefit. That's putting the patient on the defensive. If it's our fault, they just won't come. You invite them, they're just going to DNA because they're not ready to have that conversation about the pain medicine. So you're saying, 120 milligrams of morphine is too high. They're like, well, I'm taking 120 milligrams of morphine. I'm not getting any better. You must be crazy if you want to come and try and reduce that. They just won't turn up. So again, we have to be willing to have open conversations with our patients and try to understand where they're coming from and show a bit of empathy to get to where we need to get to. So I guess this morning, what I would really like to do is to just tell you about 7 shifts that I've had to learn in my journey with old people, and to see if maybe there's 1 or 2 that you can actually use in your practice to begin to address polypharmacy in your population. God, time's gone. Okay, first, when we are identifying people, or in that early stage where we are meeting the patient, we need to change our focus from pills to people. It's always about the patient. So I'm guilty as a pharmacist. In my early days of practice, if I go to a patient's house, I'm straight to the table and I'm fiddling with all the drugs and the patient is there. And then I finish looking, I'm asking, do you take this? Do you take that? And the patient's right there. And the patient, after a while, they just go, yes, yes, yes. So I go do my medication review, I leave the house, nothing changes. And now I'm learning to go to the patient first, and then we can bring in the medicine list. So when we are identifying people in the practice, let's identify those who are the most vulnerable. Let's think about using population health tools around the important things and the things that drive inequalities in overprescribing. So let's choose the cohort that are most likely to benefit, and then we can prioritize them. In assessing how people are, let's move from how old you are to how well you are. And the wellness test, in this case, is frailty, because that is a more nuanced representation of people's life expectancy and how they're going to respond, and even their needs. Let's move from what's the matter with the medicines to what's the matter, or what matters to you. So we start with the patient, is what matters to them, and then the medicines can be aligned. Then it's also moving from the right medicines, which is about the evidence, to the right medicines for you. So it might be wise, I'm sure there must be somebody, in this world who deserves to be prescribed propranolol, in spite of everything that was said. But actually, we need to still think about the other people and the risk. So it doesn't mean we have to stop everybody taking propranolol. We just need to find out the people where it's necessary to prescribe. And maybe for those majority who is not necessary, then we need to stop it. We also need to think about move from eliminating risk totally. In complex cases, you can almost not. And it's about managing the risks properly with the patient and with the wider team. Then we need to think about moving from telling and persuading to empowering people to have shared decision-making conversations about their treatments. And finally, we need to move away from the single professional to the multidisciplinary partnerships. And that multidisciplinary team for frail old people includes everyone who's looking after them. It's the relatives, the community pharmacists, is the specialist, is the oncologist, is the consultant pharmacist, is whoever it is the GP at the center of everything, is the social prescriber, is the community group people, anybody who is relevant and who is involved. As long as we've got their consent, we need to be working together. So just a lot of what I've said, just kind of repeating myself. But again, look at your patient. Sometimes you're there and we're just yap, and looking through the medicines list and going through all the evidence base, and we have a patient. And then when you turn around, they say, well, I'm not taking any of those medicines. You've just wasted 10 minutes of your time that you could have asked at the beginning. So start with your patients. The medicine list is not the whole story, but, prepare yourself before you meet the patient. If you're not the person who knows them, just read a little bit. There's a lot. We can find a lot in the notes. Look at their social history. Look at the last consultation letter. I know I'm teaching old dogs to, how do you say, teaching old dogs to, I don't know, what I mean. But, look at about the are they on the dosage box? Can they leave home? Have they had a fall? These things impact on how they use their medicines. What's their cognition like? Do they have capacity? Do they have a universal care plan? Do they have, or advanced care plan? I don't know what you call it down here. But, we need to start with the patient. And again, I've just been talking about how old you are rather than how frail you are rather than how old you are. And check the frailty score. I don't know if you guys use frailty score here. So in England, we use the clinical frailty score. It's not always in the notes, but we're doing a lot of work now around frailty to make sure that everybody has a clinical frailty score. So that can be the starting point of assessing if somebody is a frailty score of 8 or 9. We don't need preventative medicines. They're not going to be here long enough to benefit from them unless the patient absolutely desperately wants it. Oh, sorry. This is a question I keep getting asked. Would you prescribe a statin in an 80-year-old? Or sometimes people ask me, would you prescribe a statin in an 80-year-old? Would anybody here prescribe a statin in an 80-year-old? Fabulous. That's the word I wanted to hear. It depends. Because it could be this old lady who's a gymnast, because she probably is going to live longer than me. Absolutely deserves a statin if she wants it. Or is it that old lady who, if it's that old lady who is dying, there's no point. And then the other ladies in there, maybe it depends on what's going on. If they have swallowing difficulties and they have like a million medicines and we're putting all in liquid form, do you know what? Maybe not. But if they have mild frailty and every other thing is okay and they want to take it and they can remember they're not taking too many medicines, so it depends. That's precisely. There is no, I mean, some of the guidance says you can't, the statin doesn't include people over 85. That's okay. But if that lady who's a gymnast was 85 and her cholesterol was high and she had other multimorbidities and she wants to take it, I probably would. Depends. But I'm not going to deprive her if there's going to be a benefit, because the reason why I'm in there is to make sure that there are better outcomes for the patient. Patient-centered medicines reconciliation. This is something that's very close to my heart, because you never know unless you ask. And the problem, one of the biggest problems I have, is trying to establish the number of medicines, what my patients are taking. Sometimes you can't find out. And so behind all these medicines here that you see that are not being taken, they're all my patients. And it's more common than you think. It's the odd patient that is taking all their medicines, like I said. And all these medicines are being prescribed, being dispensed, all that effort is going in. And the bottom line is the patients are not taking them. And that's because somebody hasn't listened to their story. They have so many things to say and we haven't listened. And so they're like, talk to the hand, not taking any. So we need to think about what matters. We need to move from what matters with the medicines to what matters to you. And this is all done in conversation. We need to be moving from to patient-centered, evidence-based conversations that are facilitated by better conversations with shared decision-making. So it's an exchange of thoughts. You say what's important, I say what I bring to it, and gradually we will find meeting places where we need to start from. And so this is how I think we need to be tackling problematic polypharmacy, through the frailty lens. So I told you earlier on about those things that drive frail people into hospital or worsens frailty. So it's the falls, it's the delirium, and it's reduced mobility. Or if you're describing them in a phenotype model, then it's all about the weakness and fatigue. And I'm sure you can all think of drugs that aggravate all these things. So where we can, if that drug is not absolutely necessary, we need to be saying, hold on, do you need to be on that, atenolol that's causing fatigue? Do you need to be on metformin? Metformin is a big one for me, because down where we live, a lot of people are obese and they're eating a lot when they're much younger, and a lot of them are fat. We put them on metformin. They come to around 85. The kidneys are not really up to scratch anymore. They're losing weight. They're not eating because of the anorexia and all that thing that's going on with the metformin, and they're still on, like 2 grams a day of metformin. And honestly, I've seen some old people who the metformin tablet is almost the same size as the old person, and they're really struggling to swallow. And you just think this is not right, even from not a clinical perspective. Do you know what I mean? And so we need to be thinking in our prescribing. We need to bring the bigger picture in. And just to do that, even in a more visual way, is to say, we normally have this biomedical approaches about the lungs and the bones and everything. That can be quite overwhelming. I find that very overwhelming. When I hear a patient with 20 medicines and then I see the long-term conditions and then they start to describe the type of AF, I just lose the will to live. I don't get it. So what I normally do is to go back to what's really important for old people. So I'm thinking the 5 Fs, or sometimes it's the 5 Ms, is the high fives, the mobility and mentation and all that. But I like the 5 Fs, which is about the feelings. So that's depression, dementia, delirium. There's the flow, and whether that's a wee flow or a poo flow. Or function and falls is about independence and falls. Pharmacy with an F, but it's American. So it's all about the vulnerabilities about the pharmacy and its people's future and their family and the networks. So I'm thinking in my mind, I have in the tip of my fingers, do any of these medicines have a negative impact on that before the old person? So that's how I'm thinking. Rather than thinking, I need to think about propranolol, I need to think about, metformin, and I just get overwhelmed. And they're tools to help us with, but the guidelines don't help us because the guidelines are only interested in the heart. They don't really care about the person who has the osteoporosis and osteoarthritis or any other condition. So we have to do that work. So I tend to treat what matters most. And also somebody might have, I've been to care homes and they'll go, somebody has, and I say, why are they giving paracetamol? And they'll go, I said, what's the indication? And they go, they don't know. But he had a headache maybe 12 years ago. Nobody goes back to check. Things, people move on. And even when they have long-term conditions, there might be one particular one that is dominant that they care about. I went to see an old man once. I hope I have enough time to tell this story. Anyway, he was on about 30 medicines. He was a really tall guy and he was sitting in a wheelchair, and I went to see him. I was quite deflated because half the medicines, he had interstitial lung disease, and I'm like, So I read up a little bit, and there was all these medicines. He had about 10 different medicines for his respiratory thing. So I went there to see him, and before his daughter came, he was having a chat to me, and he said, and I said to him, I'm the pharmacist, blah, blah, and he goes, and I said, while we're waiting for your daughter, just tell me what's important to you. And he says, just give me a pill so I can die. I thought, oh dear. And he goes, look at me. A big man. He was a big man. It was a man's man. Do you know what I mean? And he goes, my wife's dying next door. I can't do anything. I can't get out of this wheelchair. I went to hospital and I lost my glasses. I can't even see a wedding picture. And he was so depressed. And just give me a pill to die. And I thought, even if I could, even if I had medicines to kill you, I couldn't give you. And I was saying, is there any little thing I could do? And he goes, find my glasses. And he goes, also, I lost my dentures. And he goes, there's this little annoying thing. And he had, I can't remember, it's impetigo, one of those things. And he just said to me, and he just told me two things. And he says, I can live with her. He said, I've been a smoker all my life. He says, I can live with her. And when his daughter came, she was saying to me how he gets blue and she has to tip him over and hit her on the back. But that wasn't his problem. His main problem was just being able to read the paper and look at his wedding picture. And I went there and I did my bit, prescribed some Dactarine, got the ophthalmologist to go in, and that was all I could do. And he really valued it. So you can do something. You can do something to make a difference. I didn't prescribe any medicines because it was out of my scope. And because I'm happy to take all of them, he says, they'll be the death of me. He says, come quickly, death. It's quite morbid, actually. But yeah, that's kind of an extreme example. So let's move from the right medicines to the right medicine for you. And again, it's just laboring again that evidence-based guidelines are the beginning, they're the framework, otherwise everything turns to chaos. But we work with evidence-based guidelines, but we have to personalize it for the patient. So these are some tools that we use to identify potentially inappropriate medicines. The stop-start tool is for people who are over 65. It's arranged by therapeutic area. For example, it will go, consider stopping furosemide as first line for hypertension because there are many more safe alternatives. Consider stopping oxybutynin for urinary tract urinary incontinence in women and it gives you a list. So you just need to think about stopping. It doesn't mean you have to stop them, but it gives you a good start. The stop frail tool is almost like the stop start, but this is for people who are moderately to severely frail, who have a low life expectancy, and who we know that we won't be surprised if they die in a year. And so it goes harder. There are 25 criteria. For example, it will go, stop any medicine that this patient has persistently refused to take. It says things like biphosphonates can be stopped, especially if people are immobile or like in nursing homes where people are not getting up, so it's all that. So it's a bit more intense. And then, of course, there's something called the Think Cascade tool, which I really like. It gives you 9 prescribing cascades that are significant in all people. So SSRIs and insomnia, SSRIs and hyponatremia, and because of that, you prescribe another drug. So again, it's really useful to help to spot medicine if you're not really thinking. And then, of course, there's the anticholinergic burden score tools where you type the medicine in and then it tells you the anticholinergic burden score. The MediCheck also will tell you about the QT prolongation, constipation, dizziness. So all these things, I know in general practice systems down in London is integrated, so you can just have a quick look. But all these things are helping you to look at the evidence base, particularly around old people, so to kind of give you that head start. And then next thing we have to think about eliminating risk and managing risk wisely, moving from telling and persuading to kind of really just empowering people to have that conversation. And there are tools again that you can use. I mentioned about the brand tool is one of my favorites. It's easy to use. Sometimes I use it with the patient when I go to see them. Sometimes I send it to them ahead of time, or sometimes I can give it to them, when they've come to view and say, go have a little think about it. And they go, I don't really want to be on this medicine. I'm like, you know what? It's not that bad. And so we go through what are the benefits of taking these medicines or stopping this medicine sometimes. So like alendronic acid, for example, and, they go, I don't want to take it. And I say, well, here are the benefits of taking them. Or not taking them. Here are the risks if you don't take them. And, what are the other alternatives? Sometimes it could be vitamin D. Sometimes it can be a little bit more exercise if they absolutely don't want to take it. And sometimes, what if I leave things as they are? So we have those conversations. I give them the leaflet and say, well, go have a conversation with your family or with your son. And sometimes they phone me. It depends. But you can use these tools in several different ways. Then there's the ask 3 questions, which is the patient asking, what are my options? What are the pros and cons? And where do I get support? So all these things are there for us to just integrate and incorporate into our daily practice to make life slightly better for us and them. And there's the polypharmacy tool. So once we've decided we need to change things, let's implement those changes with the patient in mind. If you go changing too many doses and too many colors, you're going to lose the old people. So at that stage, we need to use local and national deprescribing algorithms if we have them. If we don't, just use common sense. Go slow with a lot of old people's medicines. Even if you're prescribing, you need to go slow and titrate up and get there. When you're deprescribing as well, just go slow. Be extra careful with mental health medicines, antidepressants, or anything that involves the CNS. We might need to go slightly slower. So some of you might have heard about hyperbolic tapering, where you just reduce a little dose. So you might need help with that. Give clear instructions, especially for people who have cognitive impairment. And sometimes we need to involve the people who are helping them to manage their medicines as well. So we can't leave those people out. And then this is the final thing around what happens next. Once we've decided we have this plan with the patient, we need to communicate. Oftentimes I've stopped medicines, the information hasn't gone to the community pharmacies, or it's a different pharmacist there, and they put the same old medicines we're trying to stop in the dosage box. So sometimes we can have two, the stopped and the one that we're already taking. And so we could end up giving more problems. So we need to be careful. Remember, always think about your patient. If it's somebody who has cognitive impairment, if it's somebody where social services are giving the medicines, we need to take that extra step and notify people. Otherwise, it's not going to go according to plan. We need to document properly so that anyone who's reading that information knows exactly why you've stopped that medicine. So this is what we're trying to say with our secondary care colleagues. Please, if you put somebody on amlodipine 10 milligram because they had a high blood pressure, don't just say GP review, teach us how to suck eggs, because we're not going to know. So just say to us if the blood, they were increased temporarily, just drop it if the blood pressure, because what tends to happen is we get the discharge letter from secondary care. If there is nothing alarming, it's filed away, and if the patient doesn't come into the practice, we're never going to see them until they have a fall and go back into hospital, and then they up the dose because they think they're taking the amlodipine 10, so they add hydralazine or something else, or doxazocin. I hate that drug, but there you go. But anyway, don't forget families and carers who support. We have to follow up. We have to monitor. So it's not a one-off event. We just need to kind of keep an eye. And it doesn't have to be another visit. It could be a phone call. There's so many ways we can contact people these days. I'm not going to go through the patient studies because I think I've almost run out of time. But again, this is a patient where if you look in there and you look at all the medicines that she's not taking, it gives you a clue to what happened, and it gives you a clue to understand why she was not taking certain medicines. And we were able to deprescribe so many medicines there. That's another gentleman, and he had a craniotomy. And because of that, they put him on 9 medicines when he's never taken any. And nobody thought about that patient. How is he going to manage 9 medicines? Anyway, he stopped taking a lot of the medicines because what mattered to him was around the too many medicines. He was sleeping all day, going to the loo all day, and he wanted to go back to his job as a painter, and it all had to do with the benefits money. And so he just like not taking. When I went to see him, I said, tell me how many medicines you can take. He goes 5. Eventually, we were able to do that. There's all the quetiapine, which I would never dream of stopping, but I had a word with the consultant, and he was happy to stop. He said he should have stopped this long time ago, but no GP is going to stop those medicines when it's prescribed by a consultant. Went to see him. We stopped all these medicines. 6 weeks later, he was less agitated. He had spoken to the benefits people. He was thinking about going back to work, and he had aggressive on his nose, so we had to do a double-handed victory. When I went to see him, he was calm as a mouse. Invited me for coffee, which I thankfully declined, but there you go. And it goes on, and so these are people's medicines we're prescribing all the time. If we don't have conversations with them, they're never going to take them. And so there's all these medicines in one person's house. That's a lot of money that could pay my wages or give me a promotion, but there you go. And I don't know about you here. There's the dosette box. So everybody's putting pressure on this man to have a dosette box. You know what he did? They supplied him a dosette box. He took all the hydrocodone out and he messed the whole thing up. And then I went in there and I said, I just had to stop myself from saying to this one, I told you so. But when we started to address him as an adult, he moved from 0% compliance to 70% compliance. Before I went to see him, he had 7 hospital admissions in a period of 3 weeks. I've been to see him, it's been 12 weeks now since I went to see him. We're still counting. He hasn't been back to hospital. So what are we learning? Oops. It's complex and it requires a patient-centered approach. We need to start with the patient priorities and frailty. There are multiple factors. We haven't talked about the availability of non-drug measures. We haven't talked about other things because I've just talked about the clinician bit. But we need to, when you're prescribing, prescribe with deprescribing in mind. Shared decision is a must. We have to have a collaborative approach. Secondary care people, please keep your A&G open so we can ask you questions. Primary care people, let's talk to each other. And so I guess in conclusion, I'm saying we need to shift the narrative. We need to move from pills to people. We need to stop thinking about age. Well, not stop thinking. Think about age, but more about frailty. Is more about what matters to the patient. It's about the right medicines for the patient. It's about managing risk wisely. We cannot eliminate risk in these complex situations. We need to empower patients for shared decision making. We need a multidisciplinary partnership. And I guess it's wise to use a bit of caution in an unfamiliar territory like deprescribing. But that only means we should test the water instead of diving headfirst. So it doesn't mean never going near the ocean. So thank you so much. Dip your toe in by shifting the narrative. And thank you so much for having me, and thank you for listening.